Hello everyone. Today we are going to learn about managing edema in nephrotic syndrome cases. Time and again in our pediatric practice, we encounter patients who come to the emergency department looking like this. Puffy eyes, swollen abdomen, swollen legs sometimes. The parents are anxious that what exactly has happened to the child. Some neighbors and relatives have often told them that the child's kidneys are damaged, and they often have scared them with horrifying stories of how some uncle or aunt of theirs got his kidneys damaged and is now having dialysis twice weekly since then. So the diagnosis in such a patient in pediatrics is mostly clear. You find a low serum albumin, high serum cholesterol, nephrotic range proteinuria, normal renal function tests, and you confirm the diagnosis of nephrotic syndrome and start the definitive management with oral steroids after ruling out the infection and COX. That part is fairly easy. But the problem arises when managing edema in such patients. Many cases of nephrotic syndrome show an increase in edema during the initial period of management with steroids. Compound that with the already existing visible swelling eyes, feet, abdomen, and sometimes genitals, and the parents are bound to get worried and anxious, and they often wonder and complain, is the treatment not working? Why isn't the swelling even starting to decrease? While managing edema in other cases, the first thing that comes to our mind is diuretics. But the traditional teaching in nephrotic syndrome is that nephrotic syndrome is a state of decreased effective intravascular volume. So use of diuretics can theoretically compromise the volume status even further. So the question arises, how do we manage edema in such a case? Do all the cases invariably need diuretics, or are diuretics completely contraindicated in all cases? Or is there a middle ground? If yes, what is it? We are going to explore the basics of that today. We all know edema is defined as clinically evident excess interstitial fluid. Besides congestive cardiac failure, cirrhosis of liver, severe acute malnutrition, nephrotic syndrome is one of the commonest causes of clinically apparent severe edema in a children for which the parents seek medical attention. Edema can be classified as mild, moderate, or severe depending on how much increase in body weight has the child had from his baseline. An increase of up to 7% is classified as mild, while an increase in body weight of 7 to 15% and more than 15% are called as moderate and severe edema respectively. So what is the mechanism of edema in nephrotic syndrome? There are basically two theories or two hypotheses explaining that. What are those two hypotheses called? Those are called the underfill hypothesis and the overfill hypothesis. What is underfill hypothesis? Underfill hypothesis basically tells that the first step in the development of edema is the nephrotic range proteinuria. When nephrotic range proteinuria happens, it leads to decrease in plasma protein level or hypoproteinemia or hypoalbuminemia. This decrease in plasma protein level or hypoalbuminemia leads to a decrease in plasma oncotic pressure. This decrease in plasma oncotic pressure leads to leakage of plasma water into the interstitium. This leakage of plasma water into the interstitium gives rise to a depleted intravascular volume status and is clinically apparent as edema. This leakage of plasma water reflexly stimulates the renin-angiotensin-aldosterone system, which leads to an increase in secretion of vasopressin, aldosterone, and atrial natriuretic peptide secretion, which causes sodium and water retention as a compensatory mechanism. So basically the underfill hypothesis tells that there will be intravascular volume depletion and the clinically apparent edema is primarily caused by the nephrotic range proteinuria. On the other hand, the overfill hypothesis tells that the edema, in the development of edema, the first step is not the nephrotic range proteinuria. Rather, the first step is the primary sodium retention by the epithelial sodium channel, which leads to volume expansion that leads to an intravascular volume overloaded status. This volume expansion causes an increase in capillary hydrostatic pressure, which leads to a leakage of excess fluid into the interstitium. That gives rise to clinically apparent edema. So basically what they are telling is that there are two hypotheses or two mechanisms to explain the development of edema in a case of non-nephrotic syndrome. Underfill hypothesis basically explains that the patient is in a state of relative hypovolemia. Overfill hypothesis explains that the patient is in a state of relative hypervolemia. In a particular patient, which pathological mechanism among these two is the predominant factor, that can vary. If in a particular patient the underfill mechanism is predominantly active, the patient will have clinical features or laboratory parameters suggestive of a hypovolemic state. On the other hand, if in that particular child the overfill mechanism is predominant, the features of hypervolemia can be found. So what are the features of hypovolemia? There are some clinical features which are more suggestive of a hypovolemic status in the child, such as abdominal pain mainly caused by the mesenteric ischemia, nausea and vomiting, features such as lethargy or dizziness in the child, prolonged capillary refill time, cold extremities, tachycardia or an increased heart rate, thready pulse, that means low volume tachycardic pulse, hypotension and shock. These are the clinical features which suggest the presence of a hypovolemic status in the child. Biochemical features like increase in hematocrit or a ratio of urea to creatinine more than 100 or fractional excretion of sodium less than 0.5% or a urinary potassium index of more than 0.6 also suggest a hypovolemic status in the child. If we consider imaging or radiology into our diagnosis, a decrease in inferior vena cava diameter or an increase in collapsibility index of the vena cava also suggests a hypovolemic or a fluid depleted status of the child. Point to be noted here is that the fractional excretion of sodium and the urinary potassium index cannot be taken as a reliable parameter if the patient has had recent diuretic therapy or recent administration of IV fluids. What are the features of hypervolemia then? Mainly it is suggested by three clinical features: refractory anasarca or refractory generalized edema, presence of hypertension or a increased blood pressure, and presence of dyspnea or pulmonary edema. These three features mainly suggest that the patient is in a hypervolemic status. Mainly we have to focus on the hypertension here. So whenever there is edema at the disease onset or relapse, what do? We first assess for hypovolemia and initiate the therapy with prednisolone, of course after ruling out infection and tuberculosis. If there is presence of hypovolemia, features of hypovolemia such as we discussed before, abdominal pain, low to normal blood pressure, prolonged capillary refill time, thready pulse, tachycardia, shock, all those things, cold extremities, all those things, those suggest the patient has hypovolemia. That means in that particular patient the underfill hypothesis or the underfill mechanism of development of edema is more active. That means the patient is in a fluid depleted state. That means the management of edema will actually be replacement of the intravascular fluid. That means the management of edema in this case actually will be IV normal saline administration at a standard dose of 10 to 12 ml per kilo over 30 minutes. We have to repeat that if the patient is hypotensive or in shock, and or IV albumin, that is 5% albumin at 10 to 15 ml per kilo over 30 minutes. So the point to be noted here is that if the patient has any clinical or laboratory features suggestive of hypovolemia, the patient is most likely having underfill mechanism active inside of him or her. So in that case, the management of edema will actually be fluid. It seems contradictory, but it actually is correct. The management of edema can be IV fluid or IV albumin if the patient has features of hypovolemia. And if the patient doesn't improve despite of that, we have to give oral or IV hydration, and we may follow that with IV albumin 20%. If the 5% volume doesn't work, we have to give 20% or more concentrated albumin. On the other hand, if the patient has no hypovolemia, rather features of hypervolemia, that means in that particular patient the patient has overfill mechanism or the overfill hypothesis predominant inside of him. That means the patient is not in a volume depleted state, rather volume overloaded state. So then what happens? How will you manage that case? Of course in that case we will not give fluid. because the patient is already in a fluid overloaded state. So what do? Then we assess the severity of edema, whether the child has mild edema or moderate to severe edema. How do we assess mild edema? If the increase in body weight from the baseline is up to 7%, that means up to or less than 7%, that is called mild edema, as we discussed earlier. On the other hand, if the increase in body weight is more than 7%, it is moderate. More than 15%, it is called severe. So as in patients who are hypervolemic or not hypovolemic, the patient is already in a fluid overloaded state, and as we discussed earlier, the patient has overfill mechanism working. That means the first step in the development of edema was primary sodium reabsorption or primary sodium retention. That means to manage the edema in this case, we have to do what? We have to restrict the sodium, and if needed, we have to give diuretics. So that is the management here. If the patient has mild edema, then what do? We do dietary salt restriction at 15 to 35 milligram per kilo max per day, and steroid therapy for relapse results in diuresis within 1 week usually. But on the other hand, if the patient has moderate to severe edema, this dietary salt restriction alone may not be helpful. So what do we do in that case? We have to give dietary salt restriction plus diuretics, and oral furosemide or loop diuretics are the first choice in that case. So understood, the first step in management of edema is assessment of the patient for hypovolemia, whether the patient has hypovolemia or no hypovolemia or hypervolemia. If the patient has hypovolemia, that means underfill mechanism. Underfill mechanism means intravascular fluid depleted state. We have to manage the patient by fluid and albumin. If that doesn't work, we have to further increase the fluids and we give more albumin. On the other hand, if the patient has no hypovolemia or rather hypervolemia as manifested by refractory anasarca or pulmonary edema or dyspnea or hypertension, that means normal to high BP, then we have to assess how severe is the edema. If the edema is mild, we have to proceed with just dietary salt restriction and await response by the steroid. But if the patient has moderate to severe edema, just dietary salt restriction will not suffice. We have to turn to the diuretics, among which the furosemide or loop diuretic is the first choice. We have to first try with oral furosemide. Then coming to understand the management of edema beyond this point, we have to understand some basics. So we are turning to the basics for 1 minute. This is the normal structure of the nephron. This is the glomerulus, the proximal convoluted tubule, the loop of Henle, the thick ascending limb of Henle, the distal convoluted tubule, and the collecting duct. What are the various classes of diuretics acting in different segments? Proximal convoluted tubule, the carbonic anhydrase inhibitors and the osmotic diuretics act in this segment. The loop diuretics act in the thick ascending limb of Henle. The thiazide diuretics act in the distal convoluted tubule, and the potassium sparing diuretics, that means the aldosterone antagonists, the epithelial sodium channel blockers, all of those act in the collecting duct. So what are the mechanisms by which the diuretic resistance occurs? That means if the patient doesn't respond to diuretics, what do we do? To understand that, we have to understand what is diuretic resistance. So diuretic resistance is basically failure to achieve the therapeutically desired reduction in edema even when a maximal dose of diuretic is employed. That means for furosemide it is absence of diuresis within 2 to 4 hours of oral diuretic administration. That is called diuretic resistance. So basically the diuretic is not working. So what can be the causes of diuretic resistance? There can be basically 5 causes. First, if the diagnosis is incorrect. If the diagnosis is incorrect, like suppose we have made a diagnosis of nephrotic syndrome which is actually a case of venous edema or lymphatic edema. If our diagnosis is correct, obviously our treatment won't work. If the patient is non-adherent, we have advised for steroids, we have advised for dietary salt restriction, we have advised for sodium restriction, we have advised for diuretic therapy. Those patients who don't take the medications or those patients who don't stick to our treatment plan, obviously the diuretics will seem as if it is not working. Third is, if the drug is not reaching the kidney. How the drug will not reach the kidney? First is non-adherence, if the patient is not taking. Second is, if the dose is too low, that means subtherapeutic dose administration, or too infrequent. Suppose a drug is needed twice daily or thrice daily, but if we are giving it is only once daily or every alternate day, that will not work obviously. Third is poor absorption. In nephrotic syndrome there is severe gut edema that will impair the oral furosemide absorption. that will decrease the oral bioavailability of the diuretics. So that will lead to poor absorption, that will lead to the diuretic not working. Fourth is, if there is decreased diuretic secretion, most of the diuretics except the aldosterone antagonists act from the luminal side of the nephron. That means they must reach the tubules to work. So those diuretics reach the tubules by tubular secretion. So if the tubular secretion is impaired, the tubular uptake of diuretic impaired by uremic toxins, if there is decreased renal blood flow or there is decreasing function of the renal mass, there will be impaired tubular secretion of the diuretic, which will lead to diuretic resistance. Fifth and last one is decreased renal response to the drug. What can it be caused by? If there is decreased GFR, decreased effective arterial blood volume despite an increase in extracellular volume, if there is any compensatory RAS activation as we discussed earlier, renin, angiotensin, aldosterone system activation, there is nephron adaptation. What is called nephron adaptation? Suppose if we have given loop diuretics, there will be loop diuretics. If we give, there will be more sodium retained inside the tubule, which will go to the distal convoluted tubule. So what will happen in the distal convoluted tubule? More sodium will reach the distal convoluted tubule than usual. So what will happen? The cell mass in distal convoluted tubule will hypertrophy. So if there will be hypertrophy of the distal convoluted tubule cell mass, they will retain more sodium. If there will be retainment of more sodium, there will be diuretic resistance. So that is called nephron adaptation. And if there is any concurrent use of non-steroidal anti-inflammatory drugs. So basically, what are the major causes of diuretic resistance? First is poor adherence to salt restriction or diuretic therapy if the patient is non-adherent. Second is if there is any reduced bioavailability of furosemide, which is normally 20 to 60%, but it can be impaired by gut edema. Third is if there is any impaired tubular secretion of diuretic due to hypoalbuminemia, hypovolemia, etc. And if there is any compensatory salt reabsorption in the distal tubule, that like we told, nephron adaptation. Last is nephron hypovolemia or nephron adaptation as we discussed earlier. So these are the major causes of diuretic resistance. So what can we do to overcome the diuretic resistance? So what can be the strategies to overcome this diuretic resistance? There can be two basic strategies. First is called sequential nephron blockade. Second is called continuous infusion of loop diuretic therapy or CILT. So what is sequential nephron blockade? That means we sequentially block the nephron at various places. So what does it refer to? The concurrent use of diuretics acting upon different segments of nephron. For example, if we give loop diuretic plus thiazide diuretic. Previously we learned, like in nephron adaptation, that if we block the if we use the loop diuretics, if we block the sodium reabsorption at the thick ascending limb of loop of Henle, there will be more sodium delivery to the distal part of the nephron, which will lead to the hypertrophy of the cell mass, which will lead to more sodium retention. So we have to block that also. That means if we use loop diuretic plus thiazide diuretic or a thiazide like diuretic like metolazone, so we can sequentially block the nephron at various places. That will lead to the overcoming of the diuretic resistance that was happening. Next one is continuous infusion loop diuretic therapy. That means continuous infusion of loop diuretics instead of intermittent dosing, so as to overcome the rebound sodium retention at the dosing intervals. For example, suppose we are giving the loop diuretic, suppose oral furosemide, to a patient at 8 AM and 8 PM every day. That means, suppose if we give furosemide at 8 AM, the effect will last till 12 PM or 2 PM of that day. From 2 PM to same day 8 PM, the patient doesn't have any effect of furosemide in his system. So in that period or in that time, what happens? There is compensatory or rebound sodium retention. So the effect we produced from 8 AM to 2 PM is actually overcome by the compensatory mechanisms in the body in the following 4 to 6 hours. So in that dosing interval, there is rebound sodium retention, which leads to diuretic resistance. To overcome that, what can we do? We have to give continuous infusion of loop diuretics, so that the loop diuretics will be present in the system throughout the day or continuously, so that there will not be any rebound sodium retention. So that is called continuous infusion loop diuretic therapy. So basically what have we learned? What is the sequential nephron blockade? We are already giving loop diuretics at the thick ascending limb of loop of Henle. That is leading to increased sodium delivery to the distal convoluted tubule, which is causing hypertrophy of the cell mass, which is causing the increased sodium retention, so that the effect produced by this loop diuretic is actually lost. So what do we do to compensate that? We have to block there also, that is thiazide diuretic or thiazide like diuretic. We can further produce the same effect by using another potassium sparing diuretic which acts in the collecting duct. So we have discussed up to this point. If there is moderate to severe edema, we do what? Dietary salt restriction and give oral diuretic therapy. If the oral furosemide doesn't work, or after giving oral diuretic for some period of time due to the nephron adaptation, it will become gradually less effective. So we have to do what? We have to do sequential nephron blockade. That means we have to add a potassium sparing diuretic, classically the spironolactone, if there is prolonged furosemide use. We have up to this point used loop diuretic and potassium sparing diuretic, but obviously if the patient doesn't respond to that, we have to do what next? We have to add metolazone or hydrochlorothiazide. Hydrochlorothiazide is a thiazide diuretic and metolazone is a thiazide like diuretic. So we have to add that along with the furosemide. That is called sequential nephron blockade. And if the sequential nephron blockade doesn't work, we have to use the another mechanism or another way to overcome the diuretic resistance that we discussed, that is called CILT, continuous infusion loop diuretic therapy. That is IV furosemide bolus, repeat 12 hourly followed by the continuous infusion. If this also doesn't work, we have to give IV albumin followed by IV furosemide at the end of transfusion, and obviously if this also doesn't work, we have to try isolated ultrafiltration. So what are the doses that we usually use? Oral furosemide is 2 to 4 mg per kilo per day. Oral hydrochlorothiazide is 2 to 4 mg per kilo per day. Oral metolazone is 0.1 to 0.2 mg per kilo every 12 to 24 hourly. And IV furosemide is 1 to 2 mg per kilo 8 to 12 hourly, or 1 mg per kilo bolus followed by 0.1 to 0.5 mg per kilo per hour. So this is the mechanism of, or this is the way how we manage edema in this patient. So what we did in these two patients, we assessed the patient for hypovolemia. So what did we find? In the first patient, we found abdominal pain, prolonged CRT, 3D pulse, and BP in a low to normal range. So obviously the underfill mechanism is acting in this patient. So we have to do what? We have to manage this patient by IV hydration and IV albumin. On the other hand, the patient on the right side, what did we find? We found pulmonary edema, dyspnea, and a BP in the normal to high range. That means the overfill mechanism is working in this patient. So we have to manage by what? Dietary salt restriction and diuretics as discussed earlier. So what are the key teaching points here? The management of edema in nephrotic syndrome is dependent upon the pathophysiologic mechanisms, basically underfill and overfill. The diuretic resistance is defined as a failure to achieve therapeutically desired reduction in edema despite a full dose of diuretic. The causes of diuretic resistance include poor adherence to the drug therapy or diet, pharmacokinetic issues, and the compensatory sodium reabsorption or nephron adaptation. Impaired tubular secretion of diuretics is a common cause of diuretic resistance in children, and a key strategy to overcome the diuretic resistance frequently relies on combining two types of diuretics, that is diuretic synergism and the sequential nephron blockade. Thank you.